identify, investigate, and resolve complaints that are made by or on behalf of consumers regarding their coverage. The program is also charged with helping SUD and mental health providers resolve their patients' insurance problems. And in addition to addressing insurance barriers, CHAMP advocates, of which there are about 20, social workers, attorneys, and advocates on this project that help New Yorkers gain access to substance use and mental health care treatment, including medication, including other related social determinant of health needs, including transportation, housing, and peer services. The independent office is housed at OASAS in consultation with OMH. I oversee the office, and we have a team of folks, as I mentioned. We have a helpline that's Monday through Friday, 9 a.m. to 4 p.m. Helpline, a learning community. We contract out to our specialists and our CBOs. We do quality assurance and, have monthly and quarterly annual reports to the state. And we also provide in real time, sentinel issue information that we provide to the state to talk about some of the trends that we're seeing happening and to try to help resolve some of the issues in terms, of discrimination, in terms of access to care issues. We're really proud of that. We have 3 specialist organizations that we work with, including Legal Action Center, the Medicare Rights Center, and the New York State Council for Community Behavioral Health Care. Our specialists provide technical assistance and training and work with us on complex cases. And then we have our in-community CBOs, our community-based organizations that do outreach about CHAMP in their communities, and they also provide client services in their communities. The CBOs, the CHAMP CBOs that we have include in the North Country, Adirondack Health on Staten Island, the Community Health Action for Staten Island Family and Children's Association, Family and Children's Counseling Services on Long Island, and Save the Michaels of the World. And our data is aggregated through Salesforce and through my office at OASAS. We provide individualized assistance through a coalition of regional community-based recovery organizations, 3 specialist organizations, as I mentioned, and that data that we collect on the cases informs state officials working to resolve parity and access to care issues. I want to just, pause briefly and talk about, why this is important. Rob, earlier during his keynote conversation with us, mentioned that the latest CDC reported drug overdose deaths in the U.S. surged to over 99,000. So we're almost at 100,000 people in the 12-month period ending in March 2021, which was a 31% increase from the prior 12-month period ending in March 2020. There have been more overdoses in the U.S. this year than any other year recorded since public health officials began tracking OD numbers. Among those underreported overdoses, we're also seeing a rise in suicidal completions, people who come in through the emergency rooms or are dying in community because they can't get the help that they need. And several people that I know of who've died in the last few months had been stabilized in their recovery until COVID hit, and these folks are no longer with us. So it only takes one time for someone to have a reoccurrence with their substance use and an overdose as a result. We cannot sit idly by and hope for the best or tell people that we can't take their call. So when folks call a CHAMP, we try to get them help right away. So I think that, in terms of why this is important to, to OMH and OASAS integration, I know that, for so long, and Harvey, I know that you've been working on this issue for decades, right? So, but, we've been very siloed. And we've also been defined, behaviorally by our illnesses, and that stigma and discrimination, has unintended consequences of, in fact, criminalizing us. We talk a lot about the criminalization of, substance use, of drugs, the war on drugs, but there's also been a criminalization on, people with, co-occurring mental health conditions as well. Often the way in which we're depicted in the media as being crazy or, not deserving of care. I wondered if you could talk a little bit about, some of the advocacy that has resulted now in a real conversation in how we're, integrating these worlds and really helping provide people with care.
Thank you, Stephanie. I love to do things with you when I love you. I think you're just a fabulous advocate and inspiring. And certainly I am a person in long-term recovery too. I began with a long hospitalization for severe depression, and it took me a number of years to get out of the house and get working again and do this work, which is just my calling and my pleasure and central to my recovery. I'm going to talk particularly about Medicaid. Stephanie, I think you're talking a lot about private insurance or commercial insurance. And we did a lot of work on what, the parity campaign. And I think that's what Stephanie's referring to try to have in statute that people with mental health conditions would get the same, and addiction conditions would get the same treatment as people with physical illnesses. But I want to talk a little bit about access to Medicaid and Medicaid integrated care. And OASAS and OMH are doing some really exciting things together that should help folks who have major needs. I'm going to put in the chat box one of the things that I've been a part of, and many folks have been, to move mental health services beyond symptoms and medication and illnesses and look at the social determinants of health. This is the 8 dimensions of health. If you've never seen it, it basically really covers a lot more of what we look at. And I think you do a lot in addiction world with harm reduction, but these are all the dimensions, whether it's emotional, spiritual, intellectual, financial, social, environmental, and physical. Missing there is legal. And there's a lot of folks we work with that have open charges and have very, very serious issues. But I wanted to tell you what OASAS and OMH are up to in this space. And that is they're creating something called CORE. And CORE are services that are, again, for people with major needs. And they're very focused on the social determinants. And they've taken a lot of services that were Medicaid reimbursed for the first time. Recovery services that previously were not available through Medicaid. They had a design called Home and Community-Based Services. It didn't work. It was too bureaucratic, very hard to get to the services. And again, I'm going to put something else in the chat box for you, and I hope you copy it down. But this is what the core services are like. And they are, it's coming in a second. Excuse me. Okay, community-oriented recovery and empowerment services, again, by both OMH and OASAS. And you'll see the PowerPoint from OMH and OASAS that explains what they are. And again, very much focused on the social determinants, funded by Medicaid for the first time, and much more quicker access. So in many ways, Stephanie's talking about access to private and commercial insurance, I believe, and I'm talking more about access to Medicaid, recovery, social determinant of health services. The services won't be up until February. They'll have quick access. They'll be divided into 4, not 11 or 12 sort of categories: psychiatric rehabilitation or psychosocial rehab, forgive me, which has a lot to do with employment, pre-vocational, and things like that. Peer support is another one. Family support is another one. And there's a form of treatment. And all these will be available, hopefully in a rapid way, for both people with addictions, mental health issues, or more likely both. So if you only sort of get, so one thing for me, it's look for that. Want to see that PowerPoint and look out for more information about that. because the people we serve will get integrated care. One other thing is in this budget, and what's in process is another OMH OASAS collaboration called the Crisis Stabilization Centers. And they're really important because when people are in a crisis, and we don't want people to wind up in the emergency room or arrested or shot by police or have an overdose or commit suicide or something of that nature. We want to give something to people in a crisis that is personal, peer-based, recovery-focused, and not so much about medication and symptoms and diagnosis in our case, but about the social determinants. So it's a 24-hour event, 24-hour minus 1 minute program. I would look for that as well. There's RFPs that are coming out. They'll be all over the state. And again, if you have an addiction, mental health issue, or both, and you're in a crisis, you can voluntarily take yourself over there and get integrated care. You get a nurse, get a mental health practitioner, an addiction counselor, a peer. So those two things I would look for about what OASAS and OMH are doing to increase access to the right sort of care for people. So I'll kick it back to you, Stephanie. I just wanted to get that in. Excuse me.
Yeah, and I'm really glad, Harvey, that you mentioned that. I've been working with OMH and OASAS on the new Part 600, which is, as you mentioned, the Crisis Stabilization Centers. And it will provide, that model, that integrated hybrid model. There'll be the Crisis Stabilization Center, but also the supportive crisis stabilization, which will include peers that are built into the system, and is really sort of built off of, and I know we talked a little bit about it earlier, the living room model, in really being able to have that support and assistance to folks with a mental health or substance use, condition that are in crisis, experiencing those challenges in daily life that create a risk for escalation of symptoms that can't, be reasonably managed in their home or community without supports. And so being able, and if I thought, even 5 years ago that we would be having this conversation, I thought, it was a Herculean task to really start to bring what has been such a siloed set of systems, in connection to each other. So I'm really excited about that, hoping that we really are going to really be addressing the co-occurring nature. And, I've heard all kinds of statistics, but in the work that I'm doing and the calls that I get, the 5,000 calls that we've had in the last couple of years, in which people, have been desperately trying to access care and haven't been able to. And, they almost always, I call it the trifecta. They talk about, depression, anxiety, and PTSD. Those, those three underlying mental health conditions, even with folks with, significant substance use issues, the interconnectedness of those conditions, right? And we've separated these conditions out into parts, kind of like what we do. And I love what was said in an earlier conversation with the need to holistically treat the person, right? Our conditions are not, like an eyeball versus a finger versus a, we have these complex social determinants of health issues. When I came into recovery, the first thing I needed was a safe place to live. I had to get off the streets, I had to start, learning how to move into health and wellness. And so, so treating the whole person and treating, the substance use and the mental health conditions together, I think is really going to make a difference. I wonder, Harvey, if we might want to talk a little bit about some of the success stories that we've seen in sort of with CHAMP and maybe in some of the work that you've done. Do you think that might be a
Sure.
thing to do?
Yeah. Well,
So
think about CHAMP in particular, because you're so much more familiar than I am.
okay. So we get these complex, and Harvey mentioned it, these social determinants of health issues, and the way in which, CHAMP works is often to address the whole person and to remove these barriers. But and by the way, all of the names of the folks that I'm going to talk about have been changed, so these aren't actually their names, for privacy purposes and dignity for them. But a gentleman who I'm going to call Jeff, his sister called CHAMP and was looking for methadone treatment for her brother, who was using fentanyl, heroin, benzodiazepines, and alcohol. And CHAMP had called Jeff's local OTP, but they had closed for the day. And as we know, addiction and mental health are not 9 to 5 conditions, right? So CHAMP then called the closest hospital to Jeff, but the hospital would only administer methadone to someone already enrolled in treatment with an OTP. And since Jeff was not already enrolled in an OTP, the hospital would not administer methadone. So we were able to research providers who could induce Jeff onto buprenorphine. But again, person-centered, he preferred methadone for, for very, respectable, reasons that he knew himself. And so we had called more hospitals. We did find one that could provide Jeff with methadone since he was in withdrawal until he could go to his local OTP when it had reopened the following day. Jeff's sister had driven him to the hospital that CHAMP recommended, and he was where he was treated. Another young woman, we'll call her Lily. She lived in New York City. She was insured by her father's New York employer, but attending college in Tennessee. And shortly after starting college, she was hospitalized for a mental health condition, and then returned home to New York for further treatment. Her New York providers would not clear her to return to college until she had mental health care set up in Tennessee. So Lily's mother had arranged for her to see a mental health provider in Tennessee, but Lily's insurer had denied coverage because the providers were out of network. So the plan had no in-network providers in Tennessee. Her parents had tried appealing the denials, but were not successful. So we were able to file additional appeals, which resulted in Lily's plan overturning its denials and covering her care in Tennessee. Her family was reimbursed for over $1,000 for the out-of-pocket costs. And we also helped her parents obtain a single case agreement with the plan, in which the plan and Lily's Tennessee providers agreed to treat the provider as in-network. So many folks, when you think about it, they hit a barrier with insurance. And by the way, Harvey, we see the same thing, unfortunately, on the Medicare side too. What we thought would, expedite folks getting access to care. Oftentimes, we have certain plans, Medicaid managed care plans, that create all kinds of barriers to folks being able to access care. And so we're hoping, and we're currently engaging in conversations with the Department of Financial Services on the commercial side, but also the Department of Health on the Medicaid managed care side, as well as OASAS and OMH to try to address some of these barriers. But the challenge often with folks is that you have people at the plan end who make these determinations that they don't understand the clinical criteria that puts folks in a very delicate situation in which they have to get that care right away. And so, if you're the average person, how do you know what your insurance benefits are, or what your plan says, or what even is in network versus out of network benefits? Or even if you're on a Medicaid managed care plan and you think that you should have, your pre-existing conditions and access to your substance use and mental health care treated, unfortunately, there are lots of barriers, that need to be resolved. Did you want to share, Harvey, on your end, what you've seen?
Well, certainly have seen, one of the other things that we're working on is, and maybe this is a left turn, but it's a story that's very dear to me, and that is police alternatives and the access people can then get from that, whether it's Daniel Prude or so many of the tragedies we deal with. People would otherwise wind up in the morass of our systems, in jail, in prison, or dead. And again, one more in the continuum. You know, we're going to have 988. I guess I'm more policy than stories at the minute. But, you know, when people are in crisis, they've hit a bottom and there's there's a time to really make change. People will be able to call a 1-800 number, actually a 988 number that will sort of connect them with help and counseling. And then if that doesn't work, or if they need more, go to stabilization or go to these living room or crisis respite programs. So, I mean, just the story of Daniel Prude, which is a tragic, a story of a man who is in a complete overdose from PCP, but is deemed to be being mentally ill, and is shackled and is naked and is waiting for help, and eventually is restrained in a way that causes his death. Whereas if we had had a better response that took into account mental health and addiction and health issues, he might be alive today. So these are the kinds of, he might have, been taken eventually first to the emergency room to deal with the overdose, and then to a stabilization center. So there's so many efforts we're trying to make now to change the conversation and to help people not wind up in jail, in prison, in death. And I that's what I'm focused on. Stories like that, stories of people that wind up in solitary confinement for years in a little box the size of an elevator with a little window, and they're out for 30 minutes a day. So many of them people with addiction and mental health issues, so many of them people of color. Again, access to better services and helping people leave jail and prison with services. These are the things I'm focused on anyway, Steph, because I'm really looking to see that we can end, really break into the pattern of death and despair and torture, and be able to sort of connect people with services that are OMH and OASAS. One last thing on the stabilization centers: commercial insurance, Medicare, Medicaid, they all pay for it. So there's no delay waiting to figure out if you have the right insurance. You do.
Yeah, there should be no wrong door, and certainly, if you have a life-threatening condition, right, and you have insurance and you've been paying into that system as a person in this society, that either on the commercial end or the Medicare, and it doesn't matter. Healthcare is a human right, right? It's a right. That if you go to a hospital and you have a life-threatening condition, that you're treated. Our people have been turned away time after time after time. And, particularly with COVID, where beds have been reappropriated for COVID, there's been such a fixation and a focus, and understandably so, right, on, this pandemic. But the collateral consequences have been that our people, with mental health and substance use issues, have been left behind, have been, not treated, have not been viewed as having life-threatening conditions. Just because we're not bleeding externally doesn't mean. And I've been in a number of situations in which I've had a family member call me up in a panic. They're in a hospital. Their loved one is on a gurney in a hallway, and is in acute withdrawal. And that person is being treated, I won't say the word, right, but they're being treated in an inhumane way. And yet that's acceptable, right, in certain circles. And not in our, not on my watch, I say. And I've gone up to hospitals and I've said to them, if this person leaves and something happens to them, their blood is on your hands and you will be held accountable. And I've said to advocates, like, you don't say you're not going to leave, you're afraid that this person is going to die if they're released. And it's amazing when we start to, to advocate for ourselves, and we realize, and we expect providers to treat, us with dignity and respect. That conversation that started, years ago between advocates and government, when that conversation happens and our stories have power, are brought to the halls of government, that real policy that integrates what Harvey's talking about in addressing these horrific disparities and these, in which our people are being treated as, that their human rights are being violated, quite frankly. That's when change happens. When we say no more, it's the same thing in every, in every civil rights movement, and this is our civil rights movement. So, I just, Harvey, I want to thank you for, having laid so much, advocacy foundation for us, and in the partnership that, folks on the substance use side and mental health, we're no longer separate, we're together, and we're working, in partnership to, to create a more, a society in which our people are treated with dignity and respect.
We're going to save lives, Stephanie, a lot of lives.
So are there questions that, in the chat box? I'm looking to see, I know we've got a lot of people saying yes, right on. That's awesome. Allie, is there any question that you see that we may have skipped over that might be helpful for us to answer?
There was one question from our love Lori Drescher, who asked if the crisis centers, I'm not sure if you answered this, if the crisis centers are harm reduction based or if they are abstinence based.
Yes, they're not abstinence-based, Lori. We've had multiple conversations on the state level to ensure that that does not happen. The other thing that's really important to note about this is, and what I've said to states, to the folks on the call, we can't lose people. This giving, folks a piece of paper when they're in crisis and saying, here are your referrals, that doesn't work. That doesn't save lives. We need to make sure, and we need to be able to prove that we're not only just giving folks referrals, assessing them, but that we're getting them connected to peers, and we're getting them connected to those in-community services, that we can demonstrate that connection is made, right? So that it's not just a checking off of the box, right? Oh, well, we gave them a referral. No, it has to be an actual warm handoff in which we can demonstrate that connection is made, and that there's follow-up for that person, so that we ensure that they're continuing to get the support that they need.
Several more questions. What I'm going to say is that after each of these sessions, there's actually a networking booth created. Stephanie and Harvey, I don't know if you can go there. If you click on networking, there should be a continued conversation on this, where you can keep having these conversations. There's some questions about the crisis stabilization centers, and nothing that we can't continue to answer too. I can put my email in the chat. I'm sure Stephanie and Harvey can put theirs, and we can get your questions answered. I know this was a short session, but it was such a good session, and just really, really appreciate hearing from you both such leaders in the field, and just really, really appreciate your time.
Yeah, and